Hello my dear curious and studious students of surgery, myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in my surgery lecture number 53, that is the ureteral stone. In this lecture we will cover the ureteral stone, its clinical features, treatment, percutaneous methods, ESWL and URS, instrumental removal of the ureteric stone, that is the ureteric catheterization, the Armia basket, ureteric myotomy, and the open method, that is the ureteral lithotomy. Now start with me ureteral stone. Ureteral stone usually originates in the kidney. Gravity and peristalsis both contribute to spontaneous passage into the ureter and down the ureter. Nature of the stone: majority of the ureteral stone are calcium oxalate stones. Due to the spiky surface, oxalate stone is easily caught in the ureter. Stones with other composition have smooth surfaces and are often passed through the ureter without being impacted. When a renal stone enters the ureter, it is rounded or oval in shape. As it passes down the ureter, it gradually becomes elongated and enlarged. In almost all the cases, it is a solitary calculus. Dear students, here is the image of showing the types of the kidney stones, that is the white stones 10 to 15%, calcium stones 75%, cystine stones 1%, and uric acid stones 5 to 10%. Here is a clear picture of the straight X-ray abdomen showing the sequence of the ureteric stones in the left ureter. You can clearly see the radiopaque stones is clearly seen in the course of the left ureter. This is the bilateral stenting of the digestants in the bilaterally. This is the another picture of the stones in the ureter, mid ureter. This is the another picture of the ureteric stones. Now the pathological changes of the ureteral stones are: if a renal stone passes to the urine bladder through the ureter without any event, it is not detected. A ureteral stone is only detected when it causes some symptoms due to its presence in the ureter or any pathological changes to the kidney or ureter. The probable pathological changes are: first is the obstruction, infection, ulceration and diverticulum. First, obstruction. Ureteral stones are seldom completely obstructive so that urine can flow around them. Partial obstruction is usually present, but it may cause dilatation of the ureter proximal to the stone and renal pelvis. If the stone passes within a few days, there is no evidence of the renal damage, but if the stone remains, gradually hydronephrosis may develop. If the stone remains for weeks or months, irreparable damage to the renal parenchyma may occur. There are three sites of the anatomical narrowing of the ureters where a stone may be arrested. These are the pelvic-ureteral junction, when the ureter, second is when the ureter causes the iliac artery, and third is where it enters through the bladder walls. And next is the complete obstruction. In the section of the obstruction is usually, and it may cause calculous anuria or atrophy of the kidney. Second is the impaction. When the ureteral stone gets impacted, attack of the ureteric colic pass off. Such impaction usually occurs in the pelvic portion of the ureter. Occasionally, a stone may remain lodged in the ureter for many months without harming the kidney. When the stone has impacted, patient may complain of dull ache which gets worse during walking and exercise. Next point of the pathological changes in the ureteral stone is the infection. May complicate ureteral stone. This usually occurs when there is a urinostasis. Infection causes further renal damage. Pyelitis, pyelonephritis and pyonephrosis from hydronephrosis may occur due to the infection. And next pathological changes is the ulceration. Mucosal ulceration may occur in the ureter due to the infection of the stone. Such ulceration may later on lead to the stricture formation, and this is quite dangerous. Fifth is the diverticulum in the wall of the ureter may occur when the stone gets impacted and ulcerates the epithelium of the ureter. Diverticulum occurs due to the pressure necrosis, and it may lead to the even perforation with extravasation of the urine, which is extremely rare. With the formation of the diverticulum, pain totally goes off with the false belief of the patient that the stone has passed away. This is the mimic. Now the clinical features. First is the symptoms. Pain. There are two types of the pain. One is the ureteric colic and second is the fixed pain. Ureteric colic: when a stone enters the ureters and descends along it, there is an attack of ureteric colic due to the hyperperistalsis of the smooth muscles of the ureter, pelvis and calyces. When the stone is arrested high in the ureter, the pain passes from the loin to the groin along the distribution of the iliohypogastric and ilioinguinal nerves. When the stone enters in the interluminal part of the ureter, the pain is referred to the tip of the penis in the male and the strangulum in the both sexes, male and female. And the next is the fixed pain in the symptoms of the ureteral stones. When the ureteric calculus gets impacted, the ureteric colic passes off and it replaced by a dull ache. Such pain is due to the capsular tension and distension of the renal pelvis. Distension of the renal pelvis, when the pain becomes gradually severe for 1 to 2 days and then gradually subside, it suggests the complete obstruction of the ureter by the stone. This may lead to the loss of the functions and complete atrophy of the kidney later on. Next symptoms is the hematuria. Hematuria, some amount of the hematuria, however small, it may be easily occurs after an attack of the ureteric colic. Even in the absence of the infection, symptoms of urgency and frequency of the urination may be complained of when the stone is very near the bladder. And fourth is the gastrointestinal symptoms are sometimes associated with the ureteric stones. Nausea and vomiting are the often complaint of with the abdominal distension due to the peristaltic ileus may also be present. These symptoms may sometimes overshadow the renal ureteric pain. This may the mimic of the intraperitoneal pathologies like peptic ulcers, cholelithiasis and acute appendicitis. The physical signs are the skin is cold and clammy, tenderness on the abdomen and muscular rigidity. Now the investigations in the ureterial calculus are the examination of the blood routinely, urine analysis, straight X-ray, intravenous urography, cystoscopy, retrograde pyelography. When a shadow is suspected to be of ureteric calculus on straight X-ray, but excitatory urography shows no excision of dye to display the presence of non-opaque ureteric calculus. These are the benefits of the retrograde pyelography. Treatment: during the attack of the colic, sedatives like pethidine or morphine may be required. Urine by paralyzing the detrusor muscles of the bladder. Now the conservative treatment is the about 80% of the ureteric stone pass spontaneously without any complications. Progress of the stone should be observed with straight X-ray every 6 weeks. Now the removal of the stones. First is the percutaneous method. Both ESW and URS can be used to treat the ureteric stones. However, persistent obstruction, pain, failing to respond to analgesia, infection and failure of progression are all indication for intervention of the percutaneous methods. The stone in the upper third of the ureter are successfully treated by ESWL. Lower 1/3 ureteric calculi should be managed by the ureteroscopic extraction, which is more successful than the ESWL and quite easy. Instrumental removal, that is the ureteric catheterization. When the stone is small, about half centimeter, is less in diameter and is arrested in any part of the ureter, usually passes off after ureteric catheterization. The ureteric catheter is passed beyond the stone and 1 ml of the liquid paraffin is injected through the catheter. It is then withdrawn. The stone usually passes off within the few hours of the day. Second is the Darmia basket. This method is particularly used when the calculus is in the lower third of the ureter. This Darmia basket is passed through the cystoscope into the ureter and pass above the stone. The basket is now open and it is gradually withdrawn from the ureter. The open basket will catch the stone and will gradually be taken out through the ureter orifice into the bladder. And third is the ureteric meadotomy. The ureteric orifice is the narrowest part of the ureter, and if this opening is enlarged by cutting the orifice is an upwards and lateral direction with the dithermy electrodes by the cystoscope, the stone may easily pass out. The disadvantage of this procedure is that it invariably leads to urinary reflux later on. This is quite dangerous, and retrograde infection, the chances of retrograde infection is there also. Then the fourth is the intraureteric extraction. By rigid ureteroscope, the whole length of the ureter can be inspected and the stone is removed by the forceps or by Darmia basket under the direct vision. And fifth is the by proximal pushing. It may be easier to push the ureteric stone proximally as the proximal part of the ureter is most of the time more dilated. The ureter calculus is now gradually pushed upward into the pelvis of the ureter where the calculus is fragmented by ESW method, and this is with quite easy without harming to the ureter. Third is the operative method, that is the ureteral lithotomy. Removal of the stone from the ureter by the operation is known as the ureteral lithotomy. When the ureter stone is so situated that any of the above instrumental methods cannot be applied for its removal, then the ureteral lithotomy is applied. Dear students, here is the image of the showing the ESWL extracorporeal lithotripsy is being shown in this image, and this is the ureteric calculus. By the flexible ureteroscope, the Darmia basket is pushed beyond the calculus and catch it. This is the Darmia basket image. You can see to catch the stones. Here is the stone is catch in the Dharma basket. This is the another image where showing the stone is catch in the Dharma basket and push it down. This image showing the ureteric meadotomy by the dithyramine electrodes has been shown in this image, and this is the open method showing the ureteral lithotomy where the all percutaneous method has been failed, not can be applied, not in position to apply it, then the definitely goes for the ureteral lithotomy. This is the image of the ureteral lithotomy. The indications of the ureteral lithotomy are when the stone is too large, second is the when the presence of stone is causing repeated attacks of colic, and third is the when the stone is gradually increasing in size, when there is evidence of obstruction due to presence of stone in the ureter and there is a gross infection and hydronephrosis, then the ureteral lithotomy should be performed. After the ureteral lithotomy performed, then the degestanting must be done there. Degestant is put there, and then the suturing of the ureter in the interrupted suture by the interrupted suture by the absorbable sutures material. This is the flexible ureteroscope. Catheterization of the urinary system bladder is shown in this image. Dear students, here is the end of our surgery lecture number 53, that is the ureteral stones. Thank you.